and led that process with Lorraine. And they actually then look at what we call the technical piece, but really is the technical expertise of developing a guideline, of leading the systematic reviews, of bringing to the panel the information that they need to make decisions. And again, I will not steal the narratives that likely Christine and Maureen and Jennifer will do. This is a guideline that is critically important. It's a guideline that will not serve every single organization right away, simply because some organizations, whether at home here in Ontario or in Canada or abroad, do not have yet the tools and the capacity to implement this guideline fully. But it can, to those that don't have the capacity to implement right away, what you have is where nursing is heading into the future. And to those that already can implement aspects of that, we invite you and we urge you to implement them. The sooner the better, because it will benefit the practice of nurses, of other health professionals, and of course, ultimately and most importantly, of patients in the quality of care and the outcomes of their care, and of organizations where nurses and other professionals work. Colleagues, it's beautiful to see this guideline come to fruition. Maureen, to you as the chair now, and to Vanessa that is listening to us from somewhere else in the galaxy, thank you, a deep thank you. Jennifer, you that carry this onwards to the May event at Humber River, and everybody will be invited online to Humber River. Maureen, I hope you will be able to join me in person. We will have a beautiful event there, and we will be honoring the guideline. We will be honoring Humber River that covers some of the cost of the guideline, and we will be honoring yet again Vanessa, because there is not enough honoring that we can do to her legacy. So thank you, everybody, and thank you on behalf of RNAO's Board of Directors, our President, Dr. Claudette Holloway, President-elect, NP Lamo-Dolkar, and everyone else in the board and on the staff of RNAO that is proud to see this guideline to fruition. So back to you guys, and thank you very, very much.
Thank you, Doris. Okay, so here are the objectives for today's session. So for the first half of the webinar, we'll discuss some background context about digital health technologies across a variety of settings and the value in using this new BPG to improve the safety and quality of care. We'll also go through some key definitions and provide an overview of the BPG purpose and scope, the guideline development process, and the good practice statements and recommendations included in the guideline. And then following a short break, the RNAO team will discuss next steps for kickstarting implementation and evaluation of this BPG in practice settings. And then we'll have time for questions and answers at the end of the webinar. So I'm going to pass it on to Lauren now, who will start off today's presentation by sharing more about the Registered Nurses Association of Ontario.
Thanks so much, Christine. Good afternoon, everyone. So before we get into details about the new best practice guideline, I'd like to give a bit of information on RNAO. RNAO is the professional organization representing RNs, NPs, and nursing students in Ontario. We are the strong, credible voice that leads the nursing profession to influence and promote healthy public policy and clinical excellence. A signature program of RNAO is the International Affairs and Best Practice Guidelines Center, which houses the Best Practice Guidelines program. RNAO's best practice guidelines are actively implemented across Canada as well as internationally through partnership with our best practice spotlight organizations, otherwise known as BPSOs. The health policy program is another core pillar of RNAO. The RNAO Best Practice Guideline was launched in 1999 and it is funded by the Government of Ontario. The purpose is to develop, disseminate, and actively support the uptake and sustainability of evidence-based, clinical, healthy work environment and system-level best practice guidelines to evaluate their impacts on patient, organizational, and health system outcomes. We've currently, as of yesterday, developed 54 best practice guidelines and a variety of implementation toolkits to support implementation processes. Here on this slide, you can see some examples of past best practice guidelines we've created. Here on this slide, you'll see that RNAO's integrated best practice guideline model includes 3 integrated pillars of guideline development, guideline dissemination, implementation, and sustainability, and guideline monitoring and evaluation. These 3 pillars inform one another and work in sync to improve outcomes for persons receiving care, health providers, and organizations and systems. During this webinar, we will be focusing on all 3 pillars as they relate to developing, implementing, and evaluating the clinical practice in a digital health environment new best practice guideline. It is of course important to mention our best practice spotlight organizations who enter into formal partnerships to implement our best practice guidelines. These are located across Ontario, Canada, and internationally. Over the past 2 decades, the BPSO program has spread to include over 1,000 BPSOs globally. Here on this slide, we are focusing on the core pillar that is focused on best practice guideline. This slide shows all steps that go into the BPG development processes. We will go into more detail later about each of the specific steps, including grade methodology. I'll now pass it over to our co-chair expert panel, Maureen, to take over.
Great, thank you, Lauren. It's hard to believe that computer systems were actually introduced into healthcare about 60 years ago. And it's been since then that our nursing professionals who have played a critical role in promoting and maintaining the health and well-being of individuals, families, and communities through information and communication technologies. Throughout my career, I have had the honor and privilege to work with nurses in all practice settings from across Canada to develop and implement various aspects of the electronic health record and other digital tools to streamline patient care and improve health outcomes and our nursing profession. Specifically in Ontario, starting about, it was about 20-something years ago, while I was working at Markham Stouffville Hospital, we were one of the first hospitals to implement a first of its kind integrated physiological monitoring and electronic documentation system. And it was our very own ICU nurses who led the way and actually were the mentors for other nurses to use technology in practice. Later, when I worked in long-term care, it was through the implementation of our clinical information system that we were one of the first long-term care facilities in Ontario to publicly report quality outcomes, and that was only enabled through technology. Later, when leading a provincial initiative, working with the Continuing Care eHealth, Ministry of Health and Long-Term Care, at that time, we had 42 CCACs, and everyone was doing something different. And we did not have a common approach to intake and to having a common assessment tool. So working with nurse case managers from across Ontario, we came together to really with one goal in mind, and that was to enhance our health outcomes for Ontarians and to have more effective and efficient coordination of care with our CCAC's case managers. And that is when we developed, in partnership with Dr. Hurdy's, the electronic common intake assessment tool. And that was across the 42 CCACs. And we're talking, 2 decades ago. Then in my role at Canada Health Infraway, when I was the Chief Nursing Executive, that was back in 2008 to 2016. We did not know what nurses knew about technology. So we led and developed the first ever quantitative survey of Canadian nurses regarding their access, usage, and impact of digital health on practice. And guess what? We found that nurses actually didn't have access to technology or the tools to enable this. So through that initiative, we brought together nurses from across Canada to develop the nursing electronic health record business and functional electronic requirements for the EHR. And that was to ensure that the needs of our Canadian nurses were met to ensure adoption, integration into practice, and person-centered care. And then our tagline was that nurses needed to be engaged from the outset to identify what their needs are so that form follows function. And one of the pictures you see there is our peer-to-peer program that RNAO led in Ontario, and as did other provinces across Canada. And this was to engage nurses to coach and mentor and educate other nurses on how to use technology into practice. And that really started the momentum, because it went from one to one, one to many, many to many. And then, as many of you know, that Doris, it's hard to track her down, as well as Irma Jean. So it was back, I think about in 2015 at the International Congress of Nursing in South Korea that I was successful in tracking down Doris and Irma Jean. And we had, lengthy conversation about how do we further engage and get nurses in the front window of digital health, where they need to be involved in every step, in starting with procurement, design, implementation, adoption, and optimization of digital health. So it was in Korea that, together with Doris and Irma Jean, that the idea for the Adopting eHealth Solution Implementation Strategy was born, and then it was later released in 2017. So it's so important that, technology needs to be seen as part of nursing practice. And back several years ago, many people thought technology was something separate from nursing practice. So I reached out to Cynthia Baker, who was the CEO of the Canadian Association Schools of Nursing, and working with nursing professors and other nurse leaders from across Canada, we developed and implemented the nursing informatics entry to practice competencies for RNs. And that was to ensure that clinicians in training are ready to practice in and gain value from technology, and that we develop and integrate the competencies related to the use of technology in practice into the curriculum design and educational processes. And at that time, we also established the Faculty Peer Leader Network to provide mentorship, engagement, and influence culture change related to the effective use of technology in clinical practice through innovative teaching strategies. So all of this is possible. If you go to the next slide. All of this is possible through the leadership of all nurses, that we have been able to lead and influence digital health nursing practices in enabling policies and procedures. Clinical nurses from across Canada came together, and they actually developed the value proposition of using technology in practice. So our frontline nurses said, by using technology, it allows you to use more of your time providing nursing care while enabling you to act more informed to improve patient, client, resident experiences and outcomes, even save lives. And our nurses in management positions, they said the value proposition was that it provides you with the meaningful information you need to more effectively lead your teams and make it easier for you to manage operations in response to needs. So our nursing leaders play a critical role in shaping the future of healthcare delivery, promoting excellence in patient care and advocating for the interests of both patients and healthcare professionals. So before going on, I think it's important that we do some level setting and that we outline some of the digital health terminology that we have used in the BPG. So digital health is a broad term that refers to the field of knowledge and practice associated with the development and use of digital technologies to improve health. A digital health environment is essentially any setting where healthcare providers, administrators, managers receive care, work in supportive teams to provide care and leverage digital tools. And that digital health technologies, they range from, terms from e-health, m-health, EHRs, virtual wearables, and so on. But what's most important is that when we think of digital health technologies, we need to think about how do these technologies, improve communications and collaborations by connecting electronically to the team, and how do they improve self-management of our patients and clients by connecting to the patient so that they truly are partners in care, and how then do our technologies are able to connect to evidence-based informed decision support so that our nurses can and are practicing knowledge-based nursing, and that we are having our continuous quality improvement by being able to have dashboards by connecting to quality measures. So I think I'll turn it to Christine to go over the next slide.
Before you do, Maureen, I want to ask people and invite people. We have a great participation here, over 150 people, Maureen. I want people to tweet. Please tweet using 2 hashtags, hashtag BPG for best practice guideline and hashtag BPSO. This is a guideline that we want to share wide and to everybody, and that everybody should be proud of the work that Maureen, you and the panel conducted. So would be lovely. We do have Anu here, but Anu will share tweets on behalf of RNAO staff. Is different than participants sharing. So please go ahead and tweet a storm. Thank you.
Thanks, Doris. And thank you, Maureen. So before we go on, we just wanted to discuss that digital health is really an emerging topic of research, and unfortunately, very little empirical evidence exists on the impact of digital health technologies on nurses, persons, and families receiving care. And issues related to access to technologies and ethical considerations are also lacking high-quality empirical evidence. So in this best practice guideline, most of the evidence for the prioritized research questions is of low or very low certainty as per the grade methodology that we used, which we'll discuss in more detail in a little bit. And this is really due to the lack of high quality randomized control trials in the areas of digital health that we're focused on for this guideline, and the fact that many non-randomized studies had high risk of bias, small sample sizes, and inconsistency in the results. However, the publication of the recommendations and good practice statements in this BPG are really leading the way and promoting more research on this topic and evidence-based practice in the area of digital health. Back over to you, Maureen.
Thanks, Christine. And I think after Vanessa called Doris, she called me to see if I would be interested in working with her to lead the creation of this BPG to further enhance the professional practice of nursing. So the purpose of this BPG is to foster nurses' ability to maintain, advance, and strengthen professional practice in the context of a digital health environment. So this guideline covers the skills and competencies required by our frontline clinical nurses, as well as our nurses to engage in the design, development, and evaluation of digital health, in the skills and competencies required by our nurse leaders and other leaders in all domains of nursing, and what are the enabling organizational policies and procedures to support our nurses in using technology. So the scope of this guideline is of all practice settings, and it was actually determined by the expert panel, and out of scope was going to be and is the pagers, patient portals, and robotic surgery. So this slide shows where we're in the development process. So starting from the pre-development work of this guideline back in 2021, we have come a long way, and here we are. It was released yesterday. And so we are now here at the end to present to you, obviously, the best practice guideline and the next steps on publishing it and our various dissemination strategies. None of this would have been possible, though, without the expert panel. So many of you may not know that behind the great team of the RNAO is experts, nursing experts, who have dedicated their time and expertise to develop this resource. And the expert panel also includes persons who have lived experience, and also is very much interprofessionally comprised. So we have our expert panels, of which many are here today, that represent clinical practice, education, research, and policy across social service organizations, academic institutions, practice areas, and sectors. And these experts share their insights on supporting and caring for persons in their support network. And as well, we have also, the guideline was also reviewed by 93 external reviewers from across Canada and internationally, which really enhanced the rigor of the guideline. And in the guideline, everyone's names can be found there, but I really do want to make a special shout out to Doris, as Doris never says no and is always open and encourages everyone to lead with nursing in mind and innovation. But it's through her leadership that she has made this best practice guideline and the whole Institute of Best Practices possible. So thank you, Doris. And as Doris has had indicated earlier, sadly, during the development of this guideline, Vanessa did pass away, and we dedicate this guideline in her honor. And before I turn it over to Christine, again, I've worked closely with the RNAO team, not just with this guideline, but previously, and I have to say they are amazing. And I really want to do a special shout out to Christine, Lauren, Glennis, and Efseen. And there's many other RNAO members who contributed to the development of this BPG. And so thank you very much. And Christine, thank you for your leadership. And now over to you.
Thanks so much, Maureen. Okay, so we'll now get into a little bit about the BPG methodology. So it's important to note that when we develop our best practice guidelines, we use the grading of recommendations, assessment, development, and evaluation methods to support our rigorous guideline development process. And grade methods are in line with international guideline standards, and they're used by other large organizations as well, such as the World Health Organization. So this new best practice guideline contains both good practice statements and recommendations. So I'm just going to briefly walk you through the difference between both of these types of statements. But what's really important to remember is that they're both action-oriented statements based on evidence that make the guideline something that can be implemented. And they follow the same process for implementation as well. So good practice statements are actions that must be done in practice, and they may be seen as more common sense actions, but they are not always happening in practice. Hence, there's a need to really reinforce them in the guideline. And we have high certainty that the benefits outweigh the harms, and a systematic review is not needed to determine this. In addition, researchers may no longer be conducting studies on the topic, as the benefits are well known, or the alternative to the action may be unethical, so it wouldn't really make sense to study it. Good practice statements don't receive a rating of strong or conditional, but they should nevertheless be interpreted as strong recommendations. Recommendation statements, on the other hand, are also action-oriented statements, but they're developed based on evidence from a systematic review. So they answer a research question about whether an action or intervention should or should not be done. And they're determined to be either strong or conditional by considering the benefits and harms of the action, how certain we are in the evidence, the values and preferences of people, and the impact on health equity. So on the next slide, we'll talk about the difference between strong and conditional a little bit more. So as I mentioned before, good quality evidence equates to a strong recommendation. And using the GRADE methodology, GRADE really considers randomized control trials or systematic reviews as high quality evidence, depending on their quality and rigor, of course. Whereas low or very low quality evidence equates to a conditional recommendation generally. In general, GRADE discourages expert panels from making strong recommendations based on low or very low quality evidence. And I'll just remind you again that good practice statements should be interpreted as strong recommendations. Conditional recommendations are not bad or less important. There's really just a need to consider more carefully than usual the individual patient's circumstances, preferences, and values. So perhaps not everyone would benefit from the recommended practice versus in a strong recommendation, most people will benefit from the recommended practice. So what you can see on this slide, excuse me, is a simplified PRISMA flowchart that indicates the rigorous process for the systematic reviews that the RNAO guideline team conducted for each of our recommendation questions, which are listed on the right-hand side. Our systematic reviews were aided with the help of a health science librarian, and searches were conducted in 2022 and then updated again at the beginning of this year, 2024. So to answer the research questions that informed each of the recommendations in the guideline, we screened over 22,000 articles, and of these, 261 full text articles were examined for relevance, and finally 18 articles were included in the final guideline. Each of the included studies were also quality appraised using the appropriate and validated tools. And more details on this can be found on the website under the Methodology Documents tab. So I'm just going to give a quick overview of how to read the different components of the recommendations that are within the guideline. So in the guideline, for each recommendation, you'll see the teal recommendation box at the top, which outlines the statement. And then directly underneath, it shows the strength of the recommendation and the certainty of the evidence. Underneath this, you'll see the discussion of evidence for each recommendation, and this includes 6 different components. So the first is benefits and harms, which highlights the desirable and undesirable outcomes reported in the literature. The second is values and preferences, which really discusses the preferences of persons receiving care. The third component is health equity, which highlights the impact the recommended practice could have on health outcomes across different populations or settings, and any potential barriers to implementing the recommendation in particular settings. Next, we have the expert panel justification of the recommendation, which really just gives a rationale for the panel's decision. And then following this, the 5th component is implementation tips. So this describes the who, what, where, when, and how related to implementing a recommendation or a good practice statement. And this information comes from both the systematic review evidence and the expert panel. And then finally, we have our supporting resources section, which includes any relevant resources, so websites, links, tools, etc., that relate to the intervention being discussed. So in our best practice guideline, there's 6 good practice statements and 4 recommendations that fall into 3 broad categories of practice, education, and organizational policy. The summary recommendations and good practice statements chart can also be found on pages 13 to 15 in the guideline. Due to time constraints today, we won't go into each of them in great detail, but we definitely encourage you to read them in the published guideline. So now I'm going to pass it over to Lauren and Jennifer to walk us through some of the recommendations and good practice statements.
Great. Thanks so much, Christine. So we'll start off today by going through the practice recommendations and good practice statements. So as you can see on the slide, under the practice section, there are 3 good practice statements that the panel came to. So I'll read them out quickly. So good practice statement 1, it is good practice that nurses and health providers complete an initial and ongoing assessment to determine accessibility, motivation, knowledge, and preferences of persons and families, including the suitability of the digital health technologies being used in their care. Good practice statement 2, it is good practice that nurses and health providers provide education to person and families related to the digital health technologies being used to deliver their care. Good practice statement 3, it is good practice that nurses and health providers be actively involved and engaged in the procurement, adaptation, adoption, and implementation of digital health technologies when used in clinical practice. I'll now hand it over to Jennifer, and she's going to discuss good practice statement 3.0 in more detail and give some examples. Thanks, Jennifer.
Okay, thank you. So as you can see on the screen, I'll just read out the good practice statement 3.0. It's good practice that nurses and healthcare providers be actively involved and engaged in the procurement, adoption, and implementation of digital health technologies when used in clinical practice. So you see a variety of tips below, which really speaks to, when I look from a nursing lens, it's very important to, as end users, to have nurses involved in understanding the technology, providing feedback and input wherever possible. And essentially, because they're going to be, undoubtedly the largest part of the nursing, the healthcare workforce, but also going to lead a significant amount of change management that does occur in the healthcare setting. So when you have such an amazing workforce attached to, selection and procurement and asking lots of questions specific to clinical practice, it's without a doubt then you'll have better adoption and implementation of these technologies. And what's frequently used in organizations is to train and use up this peer champion model, and sometimes we call them super users. And that undoubtedly, when you have those who are comfortable with the technology in place, they tend to influence others to adapt it as well. So I'll skip to the next slide. So I'm just going to give one example where undoubtedly, if you haven't come across an EMR, you've likely heard about an electronic medical record. And really, it's a digitization of a healthcare record. Many interfaces occur with that record, but when you think about how do they create those screenshots or those documents to begin with? So one of the exercises that we undertook at Humber was thinking about all the different players and partners and collaborators and users of the electronic medical record. And then thought about how can we enhance it for our teams here. So one of the things that we did was we actually looked at all the applicable best practice guidelines that were available to us at the time. And this really turned out to be a 3-year project. I don't want to sound like it's scary, but we wanted to be very careful and methodical in terms of how we were going to update some of the screens that we already had in place or create new ones at Humber. So as you can see, so we selected all the relevant best practice guidelines, and then we took a look at what we had in terms of our screens. Wherever possible, we were trying to understand from the nursing perspective, did we have too many fields for nurses to tick or enter data into? Were there areas that we could collapse it? Were there fields that we could actually link to each other? So I would fill out information here, it might carry somewhere else. And then was all of it rooted in terms of what was expected for best clinical practice and evidence made available through the best practice guidelines. So really, it was a good exercise that we really engaged all of the leadership teams, and there's many layers of leadership involved in this. But we also did engage our nursing staff to get their lens on, we made this modification to the screen. How does it look and feel to you? And we got a lot of feedback from them because we knew that was going to be a critical component for uptake when we went live with all the changes that we made to the screens. And that was a massive, massive project. I'm sure most of you who are involved in organizations that have some version of electronic medical record, there's a continuous exercise of updating your screens. But for us, implementing the best practice guidance was the single most important thing that we could do here at Humber River.
Great. Thanks so much, Jennifer, and for sharing the example from Humber. So we'll now move on to the next category in the best practice guideline, which focuses on education, and I'll quickly walk you through the recommendations and good practice statements. So for the education section, there is one good practice statement, which reads, it is good practice that organizations provide nurses and health providers with protected time for education related to the digital health technologies being used to deliver care. And there's 3 recommendations under the education category, which I'll quickly read. Recommendation 1.0. The expert panel suggests that health service and academic organizations provide ongoing education to nurses and health providers that includes hands-on training for the use of digital health technologies. Recommendation 2.0. The expert panel suggests that health service and academic organizations provide ongoing education to nurses and health providers that focuses on interpersonal communication skills when using digital health technologies. And lastly, recommendation 3.0, the expert panel suggests that health service organizations implement interdisciplinary peer champion models to facilitate education for nurses and health providers on the use of digital health technologies. And I'll hand it back to you, Jennifer, to speak to some of these.
Thank you. So for this good practice statement form, I'll read it out. It is good practice that organizations provide nurses and health providers with protected time for education related to the digital health technologies being used to deliver care. And when you think about anything that's going to be implemented, particularly technology these days, it really is the ask is to integrate that equipment or tool or digitized piece of practice into my existing foundation of practice. And it does take some work to figure those pieces out to make sure, my workflows are not affected, et cetera, et cetera. So one of the things that we realized as an organization here at Humber was we need to make sure that we did give staff protected time so that they could actually learn a piece of technology, really truly integrate it, and then apply it. And so what that meant was we had constant updates to orientation. We would have constant updates to our in-services. And so what you see on the screen here are 2 examples. On the top half, we decided we wanted to implement something called a News 2 score, and that's an early warning systems algorithm. And in some places this is implemented on paper, and so that's a snapshot of what it looks like on paper. And we decided we wanted to actually implement it into our vital signs machine. So on the right-hand side, what you're seeing is an example of our Welch Allyn machines. So we use these, you've probably seen them all over the place. Some version of the machine takes vital signs. And then we added the button so that once the vitals are taken, it would automatically upload into our electronic medical record, but it would also produce a score to indicate some of these vital signs are outside of limits, not normal limits, so that and there's an area of concern, or maybe they're within normal limits. So everything's as expected. So the News 2 score would actually shoot out what the expected action was, and then the nurse could actually have conversations with the patients to validate the vitals, and have conversations with the clinical teams to make sure some version of escalation occurs. So on the right hand side, that's our clinical teams actually running in services and education, because we knew it was going to take time for staff to understand we were implementing a different type of assessment, but something that would be integrated with technology that was existing in our like the vital signs machines. But it would mean a change in practice. And so that's one example. The other one is probably pretty common. So you're probably seeing digitization of your IV machines. And so we have here a SpectraLink. And then much of the information is linked to our electronic medical record. But again, as you make these changes to practice, it's very important that the staff do, again, get that time to understand what the change is being asked of them, figure out how to integrate it, and then apply it. Okay, I think Now for this recommendation, let me just read it out quickly. So the expert panel suggests that healthcare services organizations implement interdisciplinary peer champion models to facilitate education for nurses and healthcare providers on the use of digital health technologies. So what I can tell you what has happened at Humber was we opened our fully digital hospital in 2015, but the year before that, the leadership and a whole variety of champions across many different disciplines realized that they needed to actually train up and educate staff on all the digital pieces that were going to be used in practice every single day. So you're seeing things from the integrated bedside terminals, which can be used by nursing staff and by the patients and families. You're seeing 2 versions of our telephones that the nurses use for communication. On the top, you're seeing images of barcode scanning for medication safety. And on the right-hand side, you're seeing the images that we use for teaching violence prevention. Our systems talk to each other. As soon as you assess a patient for violence or agitation risk, flags come up in multiple different areas. And so that was something that we had decided we wanted to build in as a feature of interoperability. But all of these technologies really needed to be spelled out for our teams here. And it meant everybody in the building, there was no exception. Depending on their clinical role, they would have to learn the various technologies. So this was actually a really good example, I think, again, similar to the previous the statements about setting aside that protected time. But in this case, you had many different types of providers and disciplines actually working together, learning technology and being resources for each other in terms of what was being adopted.
Great, thanks, Jennifer. So finally, we'll move on to the last category, which focuses on organization and policy. So under this category, there is 2 good practice statements and 1 recommendation. So I'll quickly read those and then hand it back to Jennifer. So good practice statement 5.0, it is good practice that organizations implement policies related to digital health technologies to protect privacy, security, and confidentiality. Good practice statement 6.0, it is good practice that regulatory bodies embed digital health competencies into nursing and health provider entry to practice exams. Recommendation 4.0, the expert panel suggests that health service organizations implement clinical decision support systems, otherwise known as CDSS or early warning systems that use artificial intelligence-driven predictive analytics to support nurses and health providers' clinical decision-making. I'll hand it back to Jennifer to speak to some of these. Thanks.
Great. So for this recommendation, I'll just read out. The expert panel suggests that health service organizations implement clinical. Oh, I think you already did that. Sorry. Okay, so from a real life example, at Humber River, we actually decided, based on observing other sectors and how they monitor untoward events or adverse events, we had decided why not create a command center, something that would be very NASA style. So on the left-hand side, what you're seeing is actual shot of our command center. And you're sort of seeing like these colorful boxes that have, and we call those tiles, and those are very dedicated towards a particular service or area of clinical practice. And for us, we even have tiles that are dedicated towards patient flow, patient census, cleaning for environmental staff. But we also have a very special set of tiles. And so you see an example of that on the right-hand side. We call them our risk of harm tiles. So we actually sat down as a leadership team, and nursing was the biggest driver in this. And I have to give credit to Vanessa Burkowski, because she really wanted to make sure that we really took a look at safety events from a VPG perspective, and said that we had to have a clinical care risk tile that was dedicated just to certain best practice guidelines. So that first column that you see there, it says BPSO, it's a BPSO tile. And you might even be able to read there that we had very clearly, so you see Fell's intervention, paying goal not met, new PI, and then delirium order onset. So there were 4 best practice guidelines that we used to create algorithms. We did heavy consultation with our clinical staff, our clinical practice leaders, and our directors of nursing care to figure out what would be the most important pieces if we had to develop machine learning, which is an arm of artificial intelligence, so that we would create real-time analytics specific to clinical concerns. And so this is how we came up with, using those best practice guidelines, how to flag patients at any given time in real time in the organization that require attention. And so we had created, based on the guidelines, stratification of alerts. Initial alerts would typically go straight to the nurses' phones or to the unit tile. And then if those were not actually met in a timely fashion, then they would escalate to the command center. And so we use this as a way to make sure that we're on top of managing safety organization-wide, but really using the best practice guidance to support creating that backstop for safety. And so it's one of the things that we're so proud of here at Humber River. We hope that at some point in time in your career, you will come by and take a look at our command center so that you can replicate something of a similar nature. But it was really, really thrilling to actually have 300, 400 nurses come into our auditorium to talk about what kinds of things do we look out for when we're worried about a patient, and when we're worried about a patient's deteriorating, or we have some kind of clinical concern but try to put our finger on it. That engagement and then consultation with all the research evidence out there and the best practice guidelines. That's how we came to derive the algorithms for the BPSO tile. Really, really exciting. And we do think that the tile that we had created has had a major impact for safety in our organization. And we've seen over the years a decrease in our patient harm rates.
Okay, I hope everyone had a nice little stretch break. I'd now like to introduce Catherine Wallace, and she's going to tell us more about kickstarting implementation of this guideline.
So hi, everyone. Welcome. I'm Catherine Wallace, a registered nurse and part of the staff here at RNAO who work on the implementation science team. And I have the opportunity to work with our best practice spotlight organizations and to support them in the implementation of our best practice guidelines. And a pleasure to be with you today. So as Lauren Bailey earlier discussed, at RNAO, we have these 3 pillars as part of our best practice guideline program. It's what makes RNAO unique and stand out in the area of BPGs, that not only do we support sites in the implementation and sustainability, but also in monitoring and evaluation. So we don't stop at guideline development. We then have an integrated model that allows us also to support sites in implementation, monitoring, and evaluation. And so I'm going to focus on this second pillar of implementation and sustainability. And I've got 5 broad ideas regarding how to kickstart your BPG implementation. So as we heard from colleagues and from Maureen and Jennifer, and a huge thanks to them for being here with us and all of you that are joining as well, that there are implementation tips for the recommendations. And in addition, we want to think about how can we actually start to think about implementing this best practice guideline. So we're going to talk about actively reading the guideline, assessing contextual factors, determining the receptivity or readiness for change, assembling a change team, and completing a gap analysis. Sounds like lots of work, but as Jennifer described, making change requires a time and commitment and a systematic process. So we need to get good at making change. So to inform these implementation strategies, we have a number of resources that we utilize as coaches at RNAO, and we encourage you also, as you implement this best practice guideline, to also use these foundational resources, including our Leading Change Toolkit. This is an online implementation resource, and it's written for you, written for a nurse or a change agent, a champion, a change team to be able to make lasting improvements in healthcare. And this is evidence-based, and it integrates 2 implementation frameworks. Our social movement action framework. This is a people-led grassroots approach to change. It's a framework that focuses on how do we get people engaged in the change process and recognize that this is a critical component to making change. We heard the example, for example, from Jennifer when she said 300-400 nurses came into an auditorium and talked about making making change. That's about engaging others in that change process to make it effective. So the social movement action framework details all of the elements that make up this approach to change that includes engaging people in a change process. Then in addition, in our Leading Change Toolkit, you will find this framework. It's an older framework, but one we continue to use and find that our best practice spotlight organizations find it very helpful. It focuses on change process. How do we actually plan, make, and sustain change? And the Knowledge to Action framework, as many of you know, details these 7 action cycle phases that help us as change agents, champions, to be able to navigate a change process in a systematic and structured manner. Now, in addition to our Leading Change Toolkit, we also have our Best Practice Champions Blended Learning Series. And as you heard earlier in the presentation, champions are a key component of implementing this best practice guideline, as well as really any best practice guideline. So we have a blended learning series, a training series for someone wanting to learn more about becoming a best practice champion, and you can see we've got a QR code if you're interested in taking this series. It's freely available. And as part of this training, we have job aids to support implementation. These are new resources that were developed for champions to be able to navigate common challenges that champions can encounter. And I'm going to highlight some of these today. Again, these are available on our RNAO Best Practice Champions Blended Learning Series. You can freely access these. If you are an existing champion, then you can just download them. And if you are a new champion, then please join us for the 4-part training series. Also, as part of this blended learning series is our Champions Competencies Framework. This is examining what are the 7 roles that an effective, competent champion must have in order to be effective in their role. And I won't get into this, but you can see it includes roles like being a leader, being a communicator, being a collaborator, etc. And I'll highlight some of those throughout these 5 strategies that we're going to highlight starting now. So the first thing we want to think about is actively reading the guideline. We so much appreciate you being with us today and hearing about the guideline, but we really want you to take the time to read the full guideline, to understand the discussion of evidence, to be able to understand what the guideline is about, its purpose, scope, and the recommendation statements, as well as the good practice statements. This is being a content expert, one of the competencies of a champion. What it means is that you're able to read a guideline and understand it. Understand the differences between strong or conditional recommendations, or understand the difference between a recommendation statement versus a good practice statement. And then even better is if you're able then to convey that information to colleagues, to be a meaning or sense maker, so that others reading the guideline will be able to understand what it is about. And even better is if you're able to convey a positive attitude regarding best practices. That helps others to start to understand how we might implement this best practice guideline in our setting. It gets us thinking about actually making practice changes. So we can see a content expert is someone who is able, has the skills to be able to read a guideline and to convey what that guideline is about to others, and ideally do that as well as convey a positive attitude, get them thinking about actually making this practice change. Again, it's emphasizing that people make change, and in order for people to make change, they must understand what this change is all about. Again, our champions also know how to make change, so they know how to implement our 2 frameworks. They recognize the importance of engaging others in the change process and also how to make change as well. Second, they need to understand the contextual factors and their impact. An important takeaway is that this guideline was not written specifically for you, your setting. So we need to consider, what does this mean for us, and to recognize the powerful impact that context or setting can have on making a practice change. And context is defined as everything other than the change itself. And we know that when we implement a best practice guideline, even in one unit versus another, there can be different considerations, and those are in part based on the contextual factors. So this can be the staff, the persons, the patient population, and also the applicability of the recommendations to your setting and whether any adaptations are needed. So again, another area of focus for our champions is being a context expert, really understanding our local setting and what does that mean in terms of making this practice change. So you'll see here on the screen, on the left-hand side is a job aid that helps you with adapting a guideline recommendation to your local context. You may read the recommendation statements or the good practice statements and be able to implement, adopt, integrate that recommendation, or there may be some components that you're not able to because it doesn't fit with your setting or because of just what's available in terms of resources in your setting. So you are able to make some adaptations to recommendations, and we have a resource to help you to understand that. The key takeaway is that all the core elements of the recommendation must be included. So if you're wanting to learn more about that, if you are reading this guideline, reading the recommendations, at this time not able to adopt all of the recommendations, this tool of adaptation can be very helpful for you. Number 3 is about determining the receptivity or readiness to change. This is another example of contextual factors. It's recognizing that there are many components that make us ready or not, or receptive or not, to implementing this best practice guideline. So it can include variables, and all of these are defined by the local context. Is the change, i.e., in this case, the integration of digital guidelines, is the change, is it valued, and is it seen as necessary? If there is a timeliness and urgency to making the change, then that will increase the readiness or receptivity to adopting this guideline. Timing is another factor. What else is happening within our organizations? Do we have the available and visible leaders for the change? And that includes our champions. That the recommendations that they work, that they address a barrier to practice, and that they're workable, meaning they're feasible, something that we can actually achieve. And then that we have the necessary resources. So we can see that champions need to be advocates of change because when we have the receptivity, when it is present, these variables, then it acts as a precursor for taking action. We know that one of the preconditions for our social movement action framework is that the change is seen as valued and necessary. When we have the receptivity, it supports the emergence of change leaders and of advocates, and it sparks a positive, high-intensity energy for change. And so here we have another job aid. Again, this is part of our Best Practice Champions Blended Learning series, a job aid of a checklist of factors that influence receptivity to change. And again, you're able to download any of these free resources from our Blended Learning series, but gives you an understanding of what are all the variables that influence the receptivity or the readiness to change. And if we're not ready, if the timing isn't right or we don't have the resources, then that can impact how successful we're going to be with implementation. One of the variables of receptivity is the energy of the individuals. So you can see with the graphic on the left-hand side, there are 5 different types of energies. We tend to focus mostly on 2. One is the physical, and this is the ability to get things done. We reach our goals, we achieve milestones, etc. Also would be intellectual energy, that we have the smarts to plan, achieve, and sustain change. But we want to consider in terms of energy and whether they're present. When they're present, that helps to move change forward and makes us more ready, receptive to making change. These 3 other types of energy, and they focus on the people of change, remembering that it's people that make change, that change is very much a social process, and that it doesn't occur in isolation. So one of these 3 energy types that involves people is this social energy, that when people feel a sense of connection, of belonging, relationships, that aids with making us more ready to make change. Another type of energy would be the spiritual energy. This is focused on a shared purpose. A shared purpose could be that we have a commitment to excellence in clinical practice. And so we could use something like the Digital Health BPG as a way then of furthering that shared purpose. When we start with that, it brings a readiness for making change. And then finally is the psychological energy. The psychological energy recognizes that when we make change, that people are taking risks, that they're moving from an old way of being to a new way of being, from paper charting, for example, to using this new technology, and that they need support and help throughout that. And where there is good, positive psychological energy, that helps to support the implementation of that guideline and helps the site to be more ready, have that energy to be able to make the change. So if this is of interest to you, of looking at these 5 different types of energies and how they make teams, organizations more or less ready for change, in the Leading Change Toolkit, you will find a tool that helps you to assess your group's energy domains. It really pays attention to the people of change and recognizes how their energy can enhance and move forward a change initiative or not. Something we don't necessarily always think about when we're making a change. Next, we need to assemble a change team. And you'll notice that the picture on the right-hand side is from Humber River in the command center, or the Nassau-style center. Very exciting. And you can see lots of champions in the picture. Assembling a change team recognizes that it takes many individuals in order to make change. All of the staff, and also a core or smaller group that will work on guiding and leading the change process, because change requires a lot of planning and organization in order to occur. So we have lots of resources, again, in our blended learning series for champions to support change teams. And we recognize that change teams, they really have 2 main roles. They need to work well together, so be good inward-facing team of committed individuals. And then they also have an outward-facing role where they're working with staff, getting their feedback, getting their input, helping them to make the practice change as described in the best practice guidelines. So again, in our Champions Blended Learning series, we have multiple job aids that can help change teams with their roles, understanding their roles and responsibilities that often and should include in creating an implementation plan. So creating an action plan so that they are able to implement all of the recommendations and good practice statements. Finally, our last Kickstart implementation suggestion is to complete a gap analysis. A gap analysis is a tool in which we are comparing our current way of practice to the recommendations and good practice statements in the guideline and determining whether we are meeting those recommendations, those best practice statements, or whether they are unmet or partially met, indicating where we need to take action and create change. So again, we have lots of resources regarding this. In our Champions Blended Learning series, we've got a job aid on conducting a gap or opportunity analysis, something typically conducted by the change team with input from staff and others. And in our Leading Change Toolkit, we have a tips sheet on how best to conduct a gap analysis, a critical starting point in planning for change and prioritizing change. So again, we've got 5 different strategies to kickstart your BPG implementation. Again, reading the guideline, thinking about context, recognizing context is everything other than the change itself, and considering if you need to make any adaptations to the recommendations and good practice statements, to consider the receptivity or readiness for change with a focus on the energies for change, to assemble a change team, and to complete a gap analysis. A reminder, at RNAO, we have many ways to support you in strengthening capacity in BPG implementation. I've talked lots today about our Best Practice Champions Network. Again, our Blended Learning series is a free training series that helps champions to develop the competencies in the 7 roles that champions need to be most effective. We have our Best Practice Spotlight Organization Program, a global knowledge movement that supports organizations to implement our BPGs, including this new one. Our ACPF, or our fellowship program, that allows RNs and NPs to conduct self-directed learning and develop themselves as champions and as leaders of knowledge translation. And finally, our Best Practice Clinical BPG Institute, which is another opportunity to learn more about planning, achieving, and sustaining change. Finally, another way to enhance your learning about RNAO and implementation would be to become a member of RNAO if you aren't already. And you can see there's a QR code to learn more about becoming a member of RNAO, now with over 54,000 members at last count. So really exciting. And I think I will turn things over now to my colleague, Dr. Cristina Medeiros, and she's going to pick up a little bit on the gap analysis that I mentioned. Thanks, Cristina.
Thanks so much, Catherine, and welcome everybody. My name is Cristina Medeiros. I'm a PhD prepared registered nurse, and I'm the Senior Manager of Evaluation and Monitoring, and I am delighted to talk to you about monitoring and evaluation when it comes to this BPG. So in all of our BPGs, we have our evaluation and monitoring chart. And so what this is it's a document that guides monitoring and evaluation of the implementation and evaluation of the impact of the BPG in question. And so we use a Donna-Bedian model to inform the development of these indicators and to really evaluate quality healthcare. And this includes 3 categories: structure, process, and outcome. So structure really describes the required attributes of the health system or health service organizations to ensure quality care. It includes physical resources, human resources, and information and financial resources. Process really examines the healthcare activities being provided to, for, and with persons or populations as part of the provision of quality care. And lastly, outcome analyzes the effect of quality care on the health status of persons and populations, the health workforce, health service organizations, or health systems. So now that we know about the indicator types as part of the Donna-Bedian model, let's delve into how these indicators were developed. So our indicator process really aligns with the BPG development process, and we work closely with our guideline development team. And so it is a 6-step process where we begin with guideline selection. And then we look at our extraction of recommendations. So the drafted practice recommendations and overall guideline outcomes, as well as our good practice statements, really guide our development of our structure, process, and outcome indicators. And then we go ahead and we use these good practice statements recommendations to develop our structure indicators and our process indicators, and the outcomes of the research question are used to develop our outcome indicators. We also align our indicators with external data repositories and instruments in step 3 when we draft these indicators. And then we send these indicators out for validation from our expert panel, as well as external validation. And thank you so much to everybody who filled out those indicator validation surveys. It really provided us with some quantitative as well as qualitative feedback that we integrated to make the indicators what they are today. So thank you so, so much. And now we are at our implementation. Step 5, so these indicators are now housed within the BPG evaluation section of the BPG. And we also develop data dictionaries, which are documents that are housed within our nursing quality indicators for reporting and evaluation data system. And they are available for our, as Catherine mentioned, our best practice spotlight organizations when they are available and inquire for them to report on them. So that's super exciting. As mentioned before, as part of our step 3 process, we align our indicators with external data repositories and instruments, including global databases such as World Health Organization, Organization for Economic Cooperation and Development, as well as international databases such as Agency for Health Research Quality, RIMDS, Collaborative Alliance for Nursing Outcomes, National Database of Nursing Quality Indicators, among other databases. And we also align them with national databases. So the Canadian Institute for Health Information, for instance, or CIHI, as well as the Public Health Agency of Canada, and other different types of national databases. And we also align them with regional databases, such as Ontario Health, Public Health Ontario, Institute for Clinical Evaluative Sciences, and Better Outcomes Registry and Network. And particular to this BPG, we also aligned it with what is available from Canada Health Infoway. And so this really allows us to adhere to a collect once, report multiple times principle. And so when should you start thinking of evaluation? Really at all implementation phases. It's kind of like thinking about discharge upon admission when it comes to caring for someone that is receiving care or treatment. And so this really helps answer key questions. You know, are the BPG recommendations being used? Are staff adhering to the recommendations? Is implementation intervention working? What difference does applying evidence-based recommendations really mean in clinical practice, in particular to perhaps clinical health outcomes? And then as part of our pre-implementation, we really want to identify our evaluation team. And it's really an important part of planning for data collection and identifying team members with various different types of expertise that can help with BPG implementation and evaluation. And really engaging those people with different forms of clinical experience and leadership who understands how these changes will affect clinical care and processes. So really engaging those frontline staff, for instance, like nurses and other members of the interprofessional team, and gathering their feedback to really help identify how care processes are affected and their impact on persons who are receiving care. Also engaging, senior management or a project sponsor. And it would be also helpful to have support from people with technical expertise, especially with respect to this BPG in particular, who could really help with these quality improvement processes, how health information technology system works, and support these proposed practice changes. And so it's really important to have a really full team of different experiences and expertise when thinking about evaluation. And next, once we have our evaluation team, we think about selecting indicators. So we have our best practice guideline that we are selecting indicators for, and we conduct that gap analysis or opportunity analysis that Catherine was talking about to really identify, practice recommendations to implement. And so then the next step, according to this gap analysis, you would select the indicators. So when selecting your indicators, it's really important to consider the feasibility, your organizational priorities, and reporting requirements to really align for all three. Really think about, who can help you with this project, and where you can get this data, and where are you housing the data, and where all of this really exists, and can this be aligned with other reporting requirements and organizational priorities. And then you select those indicators that align with the BPG recommendations as part of your gap analysis or opportunity analysis. And then you consider your level of implementation. So are you implementing this on one unit, multiple units, organizational wide? And really thinking about that level of implementation. So let's say perhaps we conducted that gap or opportunity analysis as part of our selection of indicators. And we figured that recommendation 1.0 as part of the education recommendations is an opportunity for implementation. So this is the expert panel suggests that health service and academic organizations provide ongoing education to nurses and health providers that includes hands-on training for the use of digital health technologies. So we have our recommendation. And in terms of our evaluation, again, that we think of evaluation at all phases of implementation. So right at the pre-implementation phase, we are creating an evaluation plan. As this evaluation plan really sets out the details of evaluation, including what will be evaluated, how and when. And it's really like a roadmap, and it really shows that route traveled or steps taken to really reach that destination of those short-term and long-term outcomes. And it really identifies how these successes will be measured. And so these evaluation plans are not created just in one sitting, and people involved in creating these evaluation plans, really, perhaps initially brainstorm and map out a preliminary evaluation plan. And then we involve our evaluation team from all of those different expertise as well as interprofessional experiences. And then we create this logic model. And so given our gap analysis or our opportunity analysis, we prioritize recommendation 1.0. So the expert panel suggests that health service and academic organizations provide ongoing education, including the hands-on training. And so we consider our inputs in blue. And these are the resources that we need for this project. And so here we can use some educational materials, some funding, and perhaps some professional practice support to really develop and undertake this education for nurses and health providers. Next, we have our activities in orange. And these are really considering, what activities will be needed to carry out as part of this project. So perhaps we would conduct some education workshops, create those pocket cards that nurses and health providers can keep in their back pocket to kind of remember, how to use these different types of digital health technologies. And perhaps also standardize documentation to see how things are going with respect to the use of these digital health technologies. And then we have our outputs. So these are the products that are produced from the activities, and they usually provide a numeric value or attributing percentage. So perhaps, number of nurses or health providers trained, number of workshops conducted, and to Catherine's point, perhaps there are champions that are involved in this education. So maybe they are trained as well. And then you have your short-term and your long-term outcomes, which are associated with changes in knowledge, awareness, behavior, and skills. So here we have for our short-term outcome, increased knowledge and ability, and then we have our long-term outcome, which is provider satisfaction. And so you can see here the corresponding structure and outcome indicators below in red that'll help measure knowledge use and outcomes. And as I was discussing before, and as Catherine was discussing about monitoring knowledge use, we know that knowledge is a critical element in understanding whether, clinicians understand, accept, adhere, and apply these evidence-based practice recommendations. And so monitoring knowledge use really helps us answer these questions. Are these recommendations being used? Is the implementation intervention working? And so during this implementation phase, you're monitoring this knowledge use to really provide insight on the rollout of the implementation activities and changes. And so you can monitor, conceptual knowledge use. Perhaps that is, you can monitor the knowledge that describes practitioners' understanding and internalization of this knowledge and information. This may be a knowledge test, for instance, before and after this education session. And then we have our instrumental knowledge use, which is really the knowledge that has been applied in practice and as a result has influenced behaviors or actions. And this is really instrumental to that hands-on training about digital health technologies, really looking at the application of knowledge. And you can measure this by doing a chart audit to determine, what's going on in terms of that standardized documentation. And then, of course, we want to share our quality improvement data. So within healthcare, we use data at a range of different levels of the healthcare system. But for the purposes of today, we're really going to be talking about sharing your quality improvement data, which generally is anonymized, identified, and aggregated at different levels. And so there are a number of reasons why it would be important to share your data. Really, first, it helps others understand the impact of evidence-based practices on outcomes. It's also an important way to engage with your staff, those who are really making that change. And we've heard from organizations time and time again that can be very rewarding for staff to see those positive differences that they're making on quality care. And at the same time, it can be very motivating when you show data that it indicates an opportunity in care and a need for improvement and really seeing that improvement grow. And it also allows for rapid learning and feedback and wide-scale spread of best practices and improvements. And most importantly, really having access to that data and daily practice is critical in understanding those opportunities in care, which allows us to learn and improve the way that we care for persons that are receiving care, and some way also care for our staff. So if you're sharing data for quality improvement in your organization, you can also, perhaps put in the chat why it's important as well. And a couple of next steps, because we've went through a lot, really is to identify your implementation and your evaluation team and to really consider those individuals that have different expertise that they can bring to the table to really enrich your implementation and evaluation. to really consider, conducting that gap analysis and perhaps attending that champion training that Catherine was talking about that has those types of resources about how to conduct a gap or opportunity analysis. We talked about, selecting indicators that are based upon the recommendation or good practice statement that was identified as part of your gap analysis, and really develop that logic model or that evaluation plan according to the gap analysis, and then really start to develop that plan for standardized data collection. So to use those indicators and to think about, where am I going to retrieve this type of data? And can we align this with different organizational priorities? And is it feasible to do so? And also to begin that baseline data collection to really see where you are and where you have the opportunity to go and to grow.